the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Pho, founder and editor of KevinMD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today we welcome back on the show Melissa Garrity. She is a psychologist, and her KevinMD article is 3 Eating Disorder Myths That Healthcare Professionals Should Debunk. Melissa, welcome back to the show.
Thank you for having me again.
So for those who didn't get a chance to listen to our first show together, just briefly share your story and journey to where you are today.
Absolutely. So, as you said, I'm a clinical health psychologist and CEO of Phoenix Rising at Dr. G. I specialize in chronic illness, complex medical, and eating disorders. I'm also an international workshop presenter, medical gaslighting sensitivity trainer for healthcare professionals, chronic pain advocate, and a complex medical patient. So, kind of a lot going on. And I also currently have a program that supports parents who have an adolescent or young adult with an eating disorder called the Ultimate Eating Disorders Boot Camp for Parents.
So one thing caught my ear when you're mentioning medical gaslighting as it relates to healthcare professionals. What exactly is that?
Yes. So I know that there's been lots of articles on it and discussions, particularly the past year or two, about medical gaslighting in our fields collectively. And so what I've started to do is help educate healthcare professionals to kind of open their minds of if they are indeed engaging medical gaslighting, how to address any biases they have, and to just be able to do trainings to medical facilities about this really important topic that can highly impact patients.
So you're also an eating disorder specialist. You see a lot of cases as well. So from your lens as a psychologist, how do clients or patients typically present to you?
Yes. So in many ways, in fact, one of the biases I talked about in my KevinMD article was that many people incorrectly assume that people look a certain way, right? When they have an eating disorder. Or I think a stereotype a lot of the times is eating disorders only occur in teenage rich white girls. So when patients present to me with an eating disorder, it doesn't have a look. You can't for sure tell if someone has an eating disorder or not. And my age range of people I see with eating disorders is from children up until the elderly. Over the past maybe 5 years or so, actually probably more than that, I've seen people being younger and younger with eating disorders who have come into inpatient facilities, residential facilities, and then to me, outpatient as well.
So let's talk more about that KevinMD article. It's titled 3 Eating Disorder Myths That Healthcare Professionals Should Debunk. Now, for those of you who get a chance to read that article, just walk my audience through it and share the story of why you decided to write.
Yes, I decided to write it because what I've found is that there are so many myths that us as medical providers kind of just follow because that's how it's always been. And I really thought it was important just to discuss the 3 top myths. One, I just discussed that eating disorders look a certain way. Another really rampant assumption that I see in the medical community is that people need to be at a certain BMI to be healthy. And we know that insurance companies often use BMI as one of their criteria for hospital-based eating disorder treatment, but it's so outdated. It's such an outdated way to diagnose eating disorders. And also it's really important to note that BMI was not designed to measure a person's overall physical or mental health. And it absolutely does not consider factors such as age, gender, ethnicity, and body composition. So we're really trying to, in the eating disorder community, move away from BMI. It's not helpful for, and again, it goes back to like fat bias, that many people incorrectly assume that people with thin bodies are healthy merely because they are thin. And you can't just obviously assume that. One place I recommend people go if they want more information on fat bias and just eating disorders in general is the Association for Size Diversity and Health. And they're committed to practicing health at every size principles. So I think it's a really great resource for healthcare professionals to have in their pocket.
So if BMI is an outdated tool to measure or look for eating disorders, what are some of the updated tools that we can use?
Yeah. So typically it is a history. It's
Mhm.
going through what is a quote unquote normal for that person. Did they, for example, lose a lot of weight, gain a lot of weight? What kind of health problems are they? Are they purging? How often are they purging? What's their food intake like? Are they eating one meal a day? Did they take out whole food groups? So it's often this very big intake process. I know my intake process alone, when I'm seeing someone who potentially has an eating disorder, can take 2 to 3 sessions. And my sessions are 50 minutes each because it's such a diverse background. As we know, too, when a person has an eating disorder, they likely have other things as well that they're coming in with: depression, self injury, trauma. A lot of people with eating disorders do have a traumatic past, not all of them. So, again, it's about the intake and doing a thorough intake of how the person is impacted.
Your third myth that you wrote was my patient's labs come back fine. They are not medically in danger. Explain why that's a myth.
Yes. One of the most dangerous assumptions is this one. So we know that any eating disorder can be deadly at any stage. And again, a person doesn't necessarily have to look sick for the eating disorder to take their life. And that's either medically or through suicide. And it's important for people to understand that a patient's health can drastically and quickly change with an eating disorder, even if labs initially show up okay. I like to give an example of I part of what I do is I send all my eating disorder patients to get physical. If we need, cardiology, we get them involved, EKG, blood work, all of that to kind of get a baseline of where they're at. And it can be difficult because when the labs initially show up okay, the patient and their parents can then say, oh, well, see, I told you it wasn't that big of a deal. But we know from research and looking at the course of eating disorders, again, that can change. So back to the story, I sent a patient to a cardiologist. She was having some concerning problems. Her heart rate was pretty low, but she was a really great athlete. So, a lot of athletes have a lower heart rate, but the cardiologist completely dismissed that this was lower than her baseline,
Mhm.
told the family she was completely fine, and dismissed this patient having anorexia. Then we, as the eating disorder professionals, have to come back and, explain, like, actually, like, this is concerning. This is not, the patient's baseline, and go from there. So that can be quite frustrating when people aren't being collaborative with the eating disorder professionals.
So, like many clinicians listening to the show, we don't have the luxury sometimes of long intakes, and we only have sometimes 15 minutes with a patient. What kind of
Yes.
questions can you ask patients that may uncover a history that may be suggestive of an eating disorder?
Yeah, that's a great question. I think it's focusing on if there's any purging, if there's any laxatives, diuretic abuse, and, like, again, just what's the typical day? Run me through a
Mm.
typical day of meals for you. And you can kind of gather from that alone if they're having enough intake. Also, exercise. Are they over exercising? Do they almost have obsessive thoughts with exercising? And because physicians have such short amount of time, I always suggest that if anyone you suspect has disordered eating or an eating disorder, that you find them a psychologist or a counselor who specialize in eating disorders and go ahead and make that referral. And medical professionals can visit the eating disorder nonprofits ANID and NIDA to find resources of trained professionals so that your patient can go ahead and get the big intake and confirm diagnoses.
So, take us into your office. If you're talking to someone with an eating disorder, what are some of the treatment approaches that you typically use?
Yeah. So oftentimes, first we start out with just like learning about the person's history. And after we do that, what I typically like to do before we dive in, particularly if there's any trauma, is learn a baseline of coping skills, different types of grounding techniques. And then we start to kind of elevate into doing a timeline of sorts of, okay, did you notice that the first time you had body image difficulties was around when you were 8 years old and your mom just happened to start dieting then? And so we
Mhm.
kind of go through that. The thing about eating disorders is that sometimes people don't know why or how their eating disorder started. And the thing is, it's okay. You don't know. And sometimes we will never know. But the thing is, we can still treat it and still move forward. So, but it is nice to kind of honor if patients do know kind of what started triggering, because it's oftentimes many events and many things over the years that triggered. So then we go into that and then we progress. We can have experiential activities such as exposure therapy of we eat certain fear foods in sessions. And also we're working on body image because that's usually a big component for people with eating disorders. And I like to say something that people don't like to hear, but is important, that body image with eating disorder recovery is the last thing to get better. And if you think about it, it makes sense because it's usually around the longest. Our society is very body focused, has very much fat phobia. And so it takes a while for body image to start to not consume a person. So it's definitely a long list of things, of base things that I adapt to the patient because not everyone's going to get the same treatment. Some people might have to then have additions of self-injury treatment and different sort of things tailored to them, and it just doesn't fit in one box. But that's kind of a basic overview.
We're talking to Melissa Garrity. She's a psychologist, and she wrote the KevinMD article, 3 Eating Disorder Myths That Healthcare Professionals Should Debunk. Melissa, what are some of your take-home messages that you want to leave with the KevinMD audience?
Yeah, the level of complexity of eating disorders definitely needs to be addressed by properly trained professionals. And patients should have a team in place that includes a medical professional, an eating disorder psychologist or counselor, and an eating disorder dietitian. It's so important to be able to have that team so a patient can recover.
Melissa, thank you so much for coming back on the show and sharing your time and insight.
Thank you so much for having me.